if you go through it, then it will help in your studies, further studies it will help you. Just listen. It is some of where you'll have to give stress. I will tell you. These are the points to be stressed for your undergraduate course, but basically this is a postgraduate subject. I have tried to make it as simple as possible for you. Ataxia is another approach design. In our previous class, you remember that we have discussed about these involuntary disorders, involuntary movements, the tremor, dystonia, athetosis. These all discussed in our previous class. These are all involuntary movements. Patients has no voluntary control over their tremor, over the dystonia, over the athetosis, over the balismus. But here, in case of ataxia, if you see the patient sitting, you cannot detect it because it is not a static events. It only this abnormal movement starts when the patient's trying to some voluntary work. So this is the difference between our previous class and this class. Try to understand this first. In previous class, it was an involuntary movement that you can see in your bare eye. The patient is having tremor like this. You can see it. But here, if the patient is sitting or even standing, you cannot detect it. But when the patient starts walking, or when the patient starts raising of his body from the chair, you will see some abnormalities in posture and also in gait. That is ataxia. Now, approach to ataxia it has come from the Greek word ataxis, that is without order, and it is the impaired coordination of voluntary motor activity. Thus, your voluntary motor activity, which you have learned from your birth, that is not, there is unsteadiness in gait, unsteadiness in posture and standing also, and there is imbalance. This will be true, may be apparent. Apparent because of that, if the patient has a hip fracture, then he has some abnormalities in gait, but that is not ataxia. Some of the will come later if we get time. We will touch up some myopathies in the later slides. Myopathies means there is proximal muscle weakness. You know that in Guillain-Barré syndrome and in many infective neuropathies, there is proximal muscle weakness. If the patient has proximal muscle weakness, then patient will have abnormalities in standing and walking. We have seen that the different gaits are there. Anyway, so but this is not ataxia. Ataxia means it is the weakness is due to some other reason. What the lesion may be? Lesion may be in the cerebellum. In the cerebellum, we call it cerebellar ataxia. When the lesion is in the posterior column, you know, posterior column, the tract of Gall and tract of Budek in the posterior part of the spinal cord, they are posterior column. They carries the proprioception and also sense of position and posture. When they are affected, there will be ataxia. So, ataxia may be in the cerebellar lesions or maybe in the posterior column lesions, and also the large fibers, peripheral nerves, dorsal root ganglia and medial lemniscus. All these lesions can cause disturbance in posture and gait. They are called sensory ataxias. So, there are, at least you remember, ataxias may be lesion in the cerebellum or maybe lesion in the posterior column. That you have to know at least. In the cerebellar, it is called cerebellar ataxia. If the posterior column of the spinal cord is affected, it is called sensory ataxia. Sensory ataxia. Ataxia may also occur when there is a frontal lobe lesion. It is call it frontal ataxia. Ataxia may also occur, very common, when the vestibular system is affected. That is, vestibular system, you know, the vestibular nucleus in the brain stem. It has a connection with the cerebellum, by vestibular cerebellar tract. It has connection with the thalamus and the vestibular spinal tract. It is also controlling the spinal cord, the spinal cord also. So, vestibular nucleus when disturbed, or its connection with the cerebellum is disturbed, then there will be ataxia. It is called vestibular ataxia. At least you remember, I told you, at least you remember these two. There is the ataxia with cerebellar lesions or maybe lesion in the posterior column. You can read it by difficulty, I don't know. There is a difference between sensory ataxia and cerebellar ataxia. Very important to remember this slide. for your examination purpose. If the patient, suppose a patient in your exam given, the patient cannot stand but cannot walk properly, then you have to detect it whether it is a sensory ataxia or it is a cerebellar ataxia. If there is static movement, you can tell it is what is an involuntary movement. But the patient is quiet when it is, he was quiet when he starts walking, has some abnormality in movement, then it is called ataxia. So there may be cerebellar ataxia or sensory ataxia. That I told you the two main types. Lesion is in the cerebellum and in the posterior column. You have to detect. You may try to detect it. So cerebellar ataxia is a scanning speech. Cerebellar disorder is scanning speech. Scanning speech is a broken speech. Like if you ask the patient to pronounce the word constitution. Suppose utter the word constitution. Patient will utter it like this: constitution. So it is a scanning speech. Patient cannot utter the constitution, the word at a stage. There is a scanning speech. So scanning speech is a scanning speech is a feature of just a second. Scanning speech is a cerebellar ataxia. Scanning speech, the speech is broken like this, constitution. But sensory ataxia, speech is usually not affected. We have told you that in a slurred speech, slurred speech in a corticospinal tract, the same constitution word will utter like the constitution. This is the utter. This is called slurred speech. But scanning speech, I have uttered this consti like this. So, but in the sensory ataxia, if the posterior column is affected, then speech is normal. Nystagmus and other ocular signs are present in ocular cerebellar lesions, but these are absent in sensory ataxia. Nystagmus, if the patient if nystagmus in the when you tell the patient to do outwards like this, you see like this in the right side, then there is a movement, there is an oscillatory movement in your eyeball. That is called nystagmus. And nystagmus has a two component. It is the faster component and a slower component. So it is always described as where the faster component is. Suppose you looking in the right side and there is a nystagmus oscillation. The faster component is towards the right. We call it is a nystagmus to the right. If the faster component is to the left, we call it a nystagmus to the left. So nystagmus occurs in different diseases. Even your impaired vision can cause nystagmus. You cannot fix the object. That causes nystagmus. So even your impaired vision can cause nystagmus, has different causes of nystagmus. But you remember at this stage that cerebellar lesion is an important cause for nystagmus. If you tell the patient to look lateral side, left or right, the patient will have an oscillatory movement in the eyeball. That is called nystagmus. But this nystagmus is absent in sensory ataxia in the posterior column lesion. In cerebellar lesions, the sensory examination normal, Romberg sign test is negative. But here sensory loss is there may be sensory loss and the Romberg sign is positive. Very important for examination purpose. This is probably the most important. How to see the Romberg sign. Romberg sign means if the patient stands right in the erect and eyes open, patient can stand. Slightly foot is slightly apart, patient can stand. But if you ask the patient to close his eyes, he cannot stand. Close his eyes, then he starts reeling. When you tell the patient to close his eyes, that is when his eyes are open, he can stand. But if the eyes are closed, he cannot stand. He gets swaying starts in his closed eyes. This is called Romberg sign. This Romberg sign is positive. You may be asked in your exam to show the Romberg sign. This Romberg sign is positive in sensory ataxia, that is posterior column lesion. Romberg sign is negative in cerebellar lesions. That is the most important test we do in bedside, whether it is a cerebellar ataxia or it is a sensory ataxia. The Romberg sign. Okay. Then is a then reflexes. Reflexes, you know that if there is a peripheral nerve disease, the reflexes will be hyporeflexia. It is a lower motor neuron lesion, so there will be hyporeflexia. But in case of cerebellar disease, a pendular reflex. Pendular reflex, if you do a knee jerk, the knee jerk jerks like this. Pendular reflex. So pendular knee jerk reflex is found in cerebellar disease. Another is there is reeling and ataxic gait. There is stomping gait. This is very important. Two gaits are there. Cerebellar disease, the gaits is reeling gait. Patients walks in the cerebellar disease, patient walks in a wide base and reeling. That is cerebellar disease. But in case of sensory disease, in peripheral neuropathy, there is you call it a high stepping gait like this. Patient walks like this, peripheral neuropathy. Difference in this sensory ataxia, when the posterior column is affected, stomping is there. Stomping is means like this. Patient walks like this. So there is a stomping. This stomping is important to know that it is sensory ataxia. So peripheral neuropathy we call it as a high stepping gait. In sensory ataxia, we get a stomping gait, high stepping. This is also high stepping, but there is a stomping. But in case of cerebellar ataxia, there is a reeling or ataxic gait. We call it a waddling gait. This cerebellar gait, we also call it as a waddling gait. This is a wide base gait. And another intention tremor. In our tremor classes, we have told that cerebellar disease has intention tremor, static tremor. They have the static tremor. We describe this static tremor is present in Parkinson's disease. Static tremor, intention tremor, when the patient goes to the close to the object, then tremor starts. We call it the intention tremor. That is a hallmark of cerebellar disease. Important side for your exam purpose, you just Romberg sign you will be asked to show if there is a disturbance in gait and posture. These slides are not very much you have to study. Then, but you should know this. Have an idea about it, and it may help in your further studies. Then ataxia may be differentiated into different types. It may be acute, subacute, chronic. It may be focal. It may be generalized, like that. So it may be cerebellar. It may be, I have told you, it may be cerebellar. It may be sensory. So in the various ways, the ataxia can be differentiated. So here you can differentiate the ataxia into the acute onset ataxia. Everybody has know that consumption of alcohol will disturb his gait. Alcohol consumption will disturb his gait. That is also ataxia. So but there is acute onset. After the consumption of alcohol, this occurs. So, but this lithium and also very important is phenytoin. Phenytoin, you know that this drug is used for convulsion and for epilepsy, convulsive diseases. This phenytoin toxicity, phenytoin overdose can cause this type of ataxia. You have to stop this drug. Barbiturates also. Post-infection like acute viral cerebralitis, varicella zoster virus. After viral infection, cerebellum may be infected and that may cause this type of acute gait. Vascular, that is also very important in old age. Like me, patient may have a stroke. That stroke, you know, there is an obstruction in the blood vessel. That can most common, there is a lenticular-striate branches of the middle cerebral artery that is called stroke, causing hemiplegia and all. But not necessarily that that artery will be obstructed. Any artery in the brain can be obstructed. So if this ICA and PICA, you know, this is anterior inferior cerebellar artery, posterior inferior cerebellar arteries. These are the arteries of the posterior system. I have taught you in some other classes. There is the anterior circulation and the posterior circulation. These are the part of the posterior circulation. Anterior inferior cerebellar artery, posterior inferior cerebellar artery. Posterior inferior cerebellar artery is the branch of the what? Vertebral artery. Anterior inferior cerebellar artery is the branch of the basilar artery. Anyway, so these things, if there is a infarct goes and stuck there, there will be vascular causes. There will be acute onset ataxia. Hemorrhage or subdural hematoma may cause it. So stroke is a cause of acute onset ataxia. Subacute, acute means comes in days. Subacute means comes in weeks. Subacute ataxia, you know, there are several causes. Most important cause is vitamin B and B12, B1 and B12 deficiency. That is the most common cause you should remember. This vitamin B12 deficiency causes subacute ataxia, and the condition is called subacute combined degeneration of the spinal cord, SCD. Subacute combined degeneration of the spinal cord. Subacute combined degeneration of the spinal cord. These cases are not uncommon because vitamin B12 deficiency and vitamin deficiency is not uncommon. It occurs in many clinical conditions. So it's a combined. Combined means it will affect the cerebellum and the posterior column both, and also it will affect the posterior column. It usually do not affect the cerebellum. Sorry, but it will affect mainly the posterior column and the corticospinal tract also. both are affected. That's why it is called combined. So posterior column is affected. We know what will happen. There is ataxia, there is disturbance in vibration, posture, etc. And etc. And if the corticospinal tract is affected, there will be features of upper motor neuron lesions. So patient will have a mixed lesions. Patient will have a disturbance in gait. Maybe there is high stumping gait because of these posterior column lesions. May have a knee jerk exaggerated because of corticospinal tract lesions, may have a plantar extensor because of corticospinal tract lesions. So the features of, but these plantar extensor and knee jerks are not the features of the posterior column affection. But here, as both the tracts are affected, corticospinal and the posterior column, that it is called combined degeneration, subacute combined degeneration, that may come as your short note. Important, not very uncommon, and it is due to vitamin D. Just write this, it is due to vitamin B12 deficiency. Effect of both the tracts and features are mixing. There is knee jerk exaggerated, plantar extensor, high stumping gait, ataxia, etc. are there, and other vitamin B12 deficiency, features of other vitamin B12 deficiency are also there. You know that megaloblastic anemia and all are there. So this thing is important. Chronic ataxia, they comes in the stage after months. So there is chronic ataxia. Here the important cause you should remember is hypothyroidism. Hypothyroidism can cause chronic ataxia. Autoimmune cause is paraneoplastic syndrome. I know I have told you in other classes that what is paraneoplastic syndrome. It is the immunological phenomena of a cancer patients. That cancer cells produces some immunological material that causes immunological damage to the system, not directly by the cancer cells or by the invasion of the cancer cells. That is an immunological phenomena. There are several antibodies produced by the cancer cell that causes autoimmune damage to the different part. That is called paraneoplastic syndrome. This can affect the cerebellum also. A small cell carcinoma of the lung. Here, there is no metastasis in the cerebellum, but cerebellum is affected because of the immunological mechanism. That is called cerebellitis, can occur as a paraneoplastic syndrome, part of the paraneoplastic syndrome. Paraneoplastic syndrome can come as a short note. What is paraneoplastic syndrome? Write that way, it is autoimmune damage. You may not write there are names of these antibodies. There are names of these anyway, there are names of these antibodies, but you may not remember all this. But still, at least it is an autoimmune phenomena. Antibody produced by the cancer cell producing some damage in the periphery. So this is important. So another is syphilis infection is also there. Now it is very uncommon. Congenital lesions are Arnold Chiari and Dandy-Walker syndrome. These are some skeletal abnormalities, congenital abnormalities seen in the upper side of upper neck that causes some skeletal. There is crowding of the neck vertebrae, and also there is a enlarged canal is very important. This syringomyelia, this syringomyelia. This Arnold Chiari malformation and Dandy-Walker syndrome. This causes cervical syringomyelia. That is syringomyelia. I have told you there is an enlargement of the spinal canal. So this occurs in this. This can also cause chronic ataxia. Inherited. This is also partly important. Inherited ataxia, not very uncommon. If you go to any neurology OPD, you will see every day they are coming. This type of ataxia patients are coming. Like you already. WhatsApp channel. So these chronic ataxias may be autosomal dominant, may be autosomal recessive, may be X-linked recessive, may be X-linked dominant, mitochondrial. These are different or inherited ataxias. These are progressive ataxias. Just I'm keeping these slides because you did not remember this. The statistic may be static ataxia, that is vascular causes. If the cause of is vascular, then it will not improve, but it may be reversible. Ataxia may be reversible. The patient may completely becomes normal after this ataxic episode. If you treat the infective cause, that will thyroid, drugs and toxins. That is a recoverable cause. Patient can recover. But this is important partly. Intermittent symptoms are episodic, also called episodic ataxias. These are due to hypokalemia or hypocalcemia. You know that hypokalemia can cause episodic weakness of the limbs. Even a hypokalemic patient comes in your ward, in your emergency, looks like a paraparesis or a quadriparesis. Just on the spot examination, you may think that patient has a paralysis, quadriparesis, 4 limbs are not moving, that actually the patient has hypokalemia, severe hypokalemia, acutely develops hypokalemia. That kind of this, but there are some causes which can cause recurrent hypokalemia. These are channelopathies. These diseases are classified as channelopathies. That is defect in potassium channel, defect in calcium channel. This is called channelopathies. These channelopathies are inherited disorders. They are not like that hypokalemia develops due to some diarrhea or like that. Not that. They are inherited disorders. They develop recurrent hypokalemia, hyperkalemia or hypokalemia. The thyrotoxicosis is an important disease. No, that thyrotoxicosis patient, they develop this recurrent hypokalemia. Anyway, these are the diseases. So, but these episodic ataxias are mainly due to hypokalemia and hypocalcemia. They are due to channelopathies. Channelopathies are inherited disorders. Anyway, so I have told you it is maybe focal, maybe symmetrical. Suppose one cerebellum is affected, then there will be focal, there will be unilateral, and you know that in the brain, the right side of the brain is reflected in the left side. I have told you that if the lesion is in the right side of the brain, the hemiplegia will be on the opposite side. But here cerebellum is projected in the same side. Any lesions in the cerebellum, left side of the cerebellum will find the lesions in the same side, the left side of the body, just opposite to the cerebrum or the brain. Cerebellum is projected, the right side of the right half of the cerebellum is affected. The lesion is the symptoms will be in the right side, left side is in the left side. So it is a unilateral projection, unlike of the cerebral hemisphere, which is projected to the opposite side. So this focal, if there is a right sided cerebral lesion, these symptoms will be on the right side. That will be called focal lesions. Localization of the lesion, you may not go to these such details. This is inherited ataxias. These are common. If you see in the OPD, in the neurology OPD, you will see every day. You will see these patients are coming with this or the inherited ataxias. I have told you it will be autosomal dominant, will be autosomal recessive, mitochondrial disturbances, X-linked recessive, and X-linked dominant. Then autosomal dominant spinocerebellar ataxia. At least 2 ataxias you remember. One is spinocerebellar ataxia, and one is muscular and cerebellar ataxias. The spinocerebellar ataxias, these spinocerebellar ataxias, there are different types. Previously called there is a pontocerebellar atrophies. There is both atrophy of the cerebellum and the pons. So it is called spinocerebellar. There is both atrophy of the spinal cord and the cerebellum. Dentorubropallidal and episodic ataxias, I have already described these episodic ataxias, these channelopathies. These are autosomal. So spinocerebellar ataxia is very common. This spinocerebellar ataxia occurs in between the age of 3 to 5 decade of onset, loss of ambulation between 10 to 15 years of age from onset, phenomena called anticipation and spinocerebellar for various ages. CAG repeat expansion is most common of them. CAG repeat, there is a, I have told you in your Huntington's chorea classes that there is a triplet repeat. There is an amino acid chain in the chromosome. In the amino acid chain in the chromosome, there is a triplet CAG. There is cytosine, adenine, and guanine. This triplet repeats. If this repeats, this triplet produces an amino acid. This nucleic acid triplet produces an amino acid called glutamine. That amino acid causes various neurological damage. This here also there is a CAG repeat. There is a this triplet repeat in the chromosome. There will be, and this will be projected in a projection of abnormal glutamine that will affect the nerve. That's the way by which the neurological features come in. The autosomal dominant ataxias, salient features. You may not remember this is just spinocerebellar ataxia is the autosomal dominant ataxia. You remember at least that thing, and it is a CAG repeat. You remember that will do. Then comes autosomal recessive. In autosomal spinocerebellar ataxia, this will help you answering MCQ. The spinal cerebellar ataxia is a 1, 2, 3, 4 autosomal dominant recessive explained. You will have to tick them on. When you are very much, if you study more, then you will find the answer. You will just search the answer in these 4 options. Otherwise, you will start thinking what will be the answer among the 4. But if you know the subject, then you will search the answer among the 4. That will save your time and give you, and also will you answer it correctly. So try to prepare in that way that you were just after just reading the MCQ, your eyes are finding the answers, whether it is in the 4, where it is in the 4. Not that I go on thinking 2 or 4, 3 or 4, not like that. Prepare like that in that way. Anyway, so it is autosomal recessive ataxias are pretty. This is very important. These two ataxia you should remember. I have told you spinocerebellar ataxia, autosomal dominant ataxia. You should remember. These two ataxias you should remember. Friedreich ataxia and ataxia telangiectasia. These are very common and also comes as a short notes and various MCQs. You will find this. If you find a neurological MCQ book, you will find various questions on these things. Friedreich ataxia and ataxia telangiectasia. These are autosomal recessive. I will come to details for Friedreich's, which is very common. Friedreich's are very common. In wards, we often see these Friedreich's ataxia patients, and this ataxia telangiectasia. These are very common, and other causes are also there. You may study or may not study if you are interested. So these are also autosomal recessive. Friedreich's ataxia, it should little bit details. You should know little bit details of Friedreich's. There is a here the repeat is GAA. You see, there is a repeat is guanine, adenine. There is a GAA repeat, not CAG repeat, and the chromosome number is in the spinocerebellar ataxia. There are different types, and the different types have different chromosome number. You cannot tell the which chromosome number is affected. Only I can tell you. You can give answer if the spinocerebellar ataxia type is related. But here, Friedreich's ataxia, it is chromosome number 9 is affected. It is not written. It is not written. Chromosome number 9 is affected, and and I told you in hereditary Huntington's chorea, we told you that is a chromosome number 4, CAA repeat, and same CAA repeat in other chromosome causes spinocerebellar ataxia. But Friedreich's ataxia, it is a MCQ. This is a GAA repeat. That is called, this gene is called frataxin gene. Frataxin gene produces a protein as that at that spinocerebellar ataxia it was glutamine, but here it is a frataxin. This protein is called frataxin. Frataxin protein is produced by this defective chromosome that will cause some damage. This is called frataxin gene, and the protein is also called frataxin protein. These are the dorsal ganglia cells, dorsal column degeneration, posterior column, there is a posterior column degeneration, spinocerebellar tract, gait ataxia and dysarthria, corticospinal tract, Babinski sign positive. Here it is a differential diagnosis with subacute combined degeneration of the spinal cord. Have you told you that they both are affected, posterior column and cerebellum? Here also posterior column, the posterior column affected and also corticospinal tract affected. That's why there is a Babinski sign is positive. Because you know that corticospinal tract is a highly myelinated tract, and there is this protein which causes damage to the myelin. That's why this combined effect. Other signs are dysphagia, optic atrophy, spinal and foot deformities. We would also call it this is pace cavas. Pace cavas. The foot is like this. Pace cavas. We call it. So spinal and foot deformities. Often there is diabetes. Cardiac defect is almost there. It is not 50%. Actually, it is much more. It may be up to 90%. Friedreich's ataxia patient will have a hypertrophic cardiomyopathy. There are different types of congenital. Friedreich's ataxia patient is usually died of cardiac disease, because the 90, it is not 50%. It is much more than that. 90% patients will have a cardiac hypertrophic cardiomyopathy. So these are the important points to be remembered. And the patient died of cardiomyopathy, heart failure. Ataxia telangiectasia is another ataxia. You should remember there is autosomal recessive disorder, oculomotor apraxia. There is the important finding is there is telangiectasia. There is vascular reticular formation is the eye. That is called telangiectasia. This telangiectasia you get in the eyes. Hematological malignancies are there. Infections, IgG deficiencies. Other features are peripheral neuropathy and chorioathetosis. This is the X-linked ataxia, X-linked recessive ataxia. This is sideroblastic anemia. This is associated with sideroblastic anemia. This is also important MCQ. X-linked ataxia is associated with which type of anemia? This is sideroblastic anemia. So treatment is not very reversible. If the cause is reversible, you can treat it. ID-Bendone is in Friedreich's ataxia. It is a drug used in Friedreich's ataxia. This is also in MCQ. Which drug is used in Friedreich's ataxia? This is ID-Bendone. And riluzole Is also used in Friedreich ataxia. This individual drug is also used in amyotrophic lateral sclerosis, the motor neuron disease. Amyotrophic lateral sclerosis, this individual is used in another disease also. That is acetazolamide in episodic ataxia, this is hypokalemic ataxias, and genetic counseling is important. So neurological examination, you know the cerebellar signs are there. You know what are the cerebellar signs? There is a titubation, head nodding, titubation, and there is nystagmus. I have told you there is abnormalities and dysarthria. I have told you dysarthria. There is scanning speech. There is intention tremor. These are all the signs of cerebellar signs. There is hypotonia and dysmetria. Dysmetria means there is a dysmetria means if the patient dysmetria means patient cannot localize. If you want to tell the patient to touch his nose, he like this. He cannot touch his nose. Dysmetria. The overpass the object. That is dysdiadochokinesia. Dysdiadochokinesia. If ask the patient to do this alternate movement. Dysdiadochokinesia. Patient cannot this movement. Alternate movement patient cannot do. The movement becomes clumsy. This is called dysdiadochokinesia. Dysenergia, etc. are there. But these are the cerebellar signs in a clinical examination, neurological examination. You should remember. Now, I will touch up this muscle disorder very quickly. There are different type of congenital muscle disorder, because you know that muscle disorders can also mimics like ataxia. They are not ataxia. They are muscle disorders, congenital muscle disorders. Difference is the cortical disorder. This is by primary dysfunction. Epidemic infancy, childhood, or adulthood may be affected. Now, classification inherited. There are inherited muscular disorders. Inherited muscular disorders. Not very uncommon. Very common is this Duchenne muscular dystrophy. Duchenne is the most common. Duchenne. Duchenne muscular dystrophy is the most common congenital myopathy. Congenital myopathy. There are Becker's. There is facioscapulohumeral myopathy. Other mitochondrial metabolic can cause this. You should remember at least two: Duchenne muscular dystrophy and Becker's, because these are very common. Duchenne is most common, but Becker and facioscapulohumeral you should remember also. Now, medication induced, maybe these myopathies may be medication induced. Muscle atrophy is the muscle dystrophy is there. How do you diagnose this case? Usually they have a high CP. There is creatine kinase enzymes are very high. This patient, because of myopathy, muscle produces this enzyme called creatine kinase. They have a very high creatine kinase. But then after the creatine kinase, if the diagnosis is there, you can do a muscle biopsy. This is called Gowers sign. These are important sign in your Duchenne muscular dystrophy called Gowers sign. The child cannot stand up. He stand up like this. These are the steps how he stands up. This is called Gowers sign. Gower. Gowers sign. It is written as a Gowers sign. These are where the patient stands up in a case of muscle dystrophy. Duchenne muscle dystrophy. If there is a short notes comes, the Duchenne muscular dystrophy, you just based on these slides you can write the short note. There are these are X-linked. There are different types of myopathies. X-linked myopathies are Duchenne muscular dystrophy, Becker's, and spinal. These Duchenne and Becker's are X-linked. They are autosomal recessive. Myopathies are there. They are limb girdle muscular dystrophy, scapulohumeral muscular dystrophy, and congenital muscular. These are autosomal recessive. These are autosomal dominant. So Duchenne D4D is Duchenne muscular dystrophy is X-linked. Duchenne muscular dystrophy the most common, and it is a X-linked. Other are autosomal recessive. And autosomal dominant myopathies are facioscapulohumeral. They are dominant distal, and oculopharyngeal myopathies are there. These are all are autosomal dominant. Now, common age group Becker's muscular atrophy. Common age group is 2 to 16 years, and Duchenne muscular atrophy age is 3 through 10 years. Clinical presentations, the inflammatory, the myopathies maybe these are the congenital myopathies I have described, but common myopathies you see are mostly inflammatory myopathies. These are found in collagen vascular disease. These are inflammatory myopathies, also called dermatomyositis when the skin is affected, also called polymyositis where the skin changes are not affected. This is the dermatomyositis. We call it the heliotrope sign. Heliotrope sign. It is written there. I don't know. This is heliotrope sign. A rash. This heliotrope rash you see, this is a classical picture. This is found in dermatomyositis. This is also a very important MCQ in your PG entrance. So the laboratory, these are the laboratory tests to establish this muscle disorder. We do a muscle biopsy or do a electromyography or biopsy. These are the tests I have told you. They establish the presence of muscle disease, creatinine kinase. CK is creatinine kinase. So do a creatinine kinase, do a EMG, and also do a biopsy. These are the important features in myopathy and neuropathy. Just remember, the proximal muscle weakness is there. There is in neuropathy, there is a distal muscle weakness. In myopathy, it starts in the proximal muscle. Tendon reflex are not affected. In neuropathy, tendon reflex are affected. This is a dystrophy. This is a muscle. This is a bladder. This is bladder. Neuropathy, there will be bladder problem. Paresthesia is a symptom. Is spontaneous pain. Unusually formed and lumpy muscles. And in neuropathy, it is a lower motor neuron lesion. Fasciculation may be there. Management. This is the last slide. This lesson. Management is inherited. Congenital myopathy and muscle dystrophy benefit mostly from the supportive treatment, physiotherapy and occupational therapy, contractual management. These are important. Duchenne muscular atrophy, the DMD, important, very important. Duchenne muscular atrophy always responsive to corticosteroids. So Duchenne muscular atrophy, which is a commonest muscle disorder, that you know that is a common, and this is responsive to corticosteroid. Acquired myopathy, systemic disease, according to the disease you inflammatory, if it is inflammatory dermatomyositis or polymyositis, secondary to collagen vascular disease, treatment is steroids or IV immunoglobulin and immunosuppressive medications. Okay, we have completed the neurology classes today, and from next Thursday there will be some other classes. Okay.